get to work, and thank you all very much for being here. And we want to thank C-SPAN for covering this important hearing. And I especially want to thank our witnesses, some of whom have traveled from very long distances from around the world to be with us today. We very much appreciate your being here. The United States has, I think, a very effective form of government in the sense that we are a federalist system, which means that we have 50 separate states, and it is very common that one state learns from what another state is doing. So every day in California or North Carolina or Vermont, somebody is coming up with an idea or a program. It works. Other people steal those ideas, learn from those ideas, and that's, I think, a pretty effective way of going forward. I do not believe that we utilize that practice as much as we should internationally. The United States is not the only country on earth. There are other countries that are doing very positive, interesting things, and we should be learning from them. And in a sense, that's what this hearing is about, is to see what we can learn from other countries around the world in terms of health care. And in my view, in fact, we have a whole lot to learn. Because at the end of the day, the United States spends far more per capita on health care. We spend almost twice as much per person on health care, and yet we have many millions of people who are uninsured, and our health care outcomes, compared to many other countries, are not particularly good. And that's my starting premise. Why is that? And what can we learn from other countries who in many ways are doing better than we can? So let me start off with just a couple of basic facts about the American healthcare system. While it is absolutely true that some Americans, often those with a lot of money, receive some of the best cutting-edge health care in the world, it is also true that for millions of low and moderate income Americans, they have little or no access to even the most basic health care services. And later on, I think maybe as part of the questions or answers, we're going to show a photograph that many of you have seen of in Virginia or California, people lining up in fields to get basic health care or to get their teeth, rotted teeth, extracted, photographs that would remind you of a third world country. The reality is that today, the United States is the only major country on earth that does not guarantee health care as a right. And that is a basic philosophical debate that we have to have. Should all Americans, regardless of their income, have access to health care as a right or not? The United States is the only nation in the industrialized world that says, no, you're not entitled to health care as a right. In 2012, more than 15% of our population, nearly 48 million Americans, were uninsured. But that's only half the story, because many people who had insurance also had high deductibles and high co-payments. And those payments created situations where people hesitated to go to the doctor when they should. Not to mention other people leaving hospital deeply in debt and going bankrupt. Is that something that we are proud of? Here's another important point to be made. We talk about rationing and so forth. Of course, in the United States, healthcare is rationed, but it is rationed by ability to pay, by income. According to a Harvard study published in Health Affairs 2009 and Health Affairs in 2014, some 45,000 Americans die every year because of a lack of access to health care. And I have talked to doctors. I don't know if my colleagues in their states have talked to doctors. I have talked to doctors who say, yeah, people walk in the door and they are now terminally ill. And the doctor said, why didn't you come in here 6 months ago? Why didn't you come in here a year ago? And people say, well, I didn't have any health insurance. I didn't want any charity. I thought I would get better. So we're losing some 45,000 people a year because they don't get to a doctor when they should. There are, furthermore, communities around this country. I know Senator Roberts of Kansas mentioned this in a hearing we had a while back, where there are no doctors. There are towns in Kansas, no doctors in the area at all. People do not have access to basic primary care. Now, despite all of that, the United States, as I mentioned a moment ago, spends almost twice as much per capita on health care as does any other country. We are spending about 18% of our gross domestic product on health care, compared to 11 to 12% in France, Germany, Denmark, and Canada, 9% in the UK, Australia, and Norway, and less than 8% in Taiwan and Israel. And we're going to hear a representative from Taiwan in a few minutes. In terms of efficiency, are we an efficient system? Compared to the huge amount of money that we're spending, are we getting good value? In August 2013, Bloomberg, a respected business source, ranked the United States healthcare system 46th of 48 countries based on efficiency. Now, what about outcomes? You know, if I'm spending $100,000 on a car and somebody's spending $20,000 on a car, we would assume that my car runs better. I'm getting better value. I'm getting value for what I pay for. Well, the United States pays almost twice as much per person for health care, but in terms of our health care outcomes, we do not do particularly well compared to other countries around the world. Among OECD countries, the United States ranks 26th in terms of life expectancy. Residents of Italy, Spain, France, Australia, Israel, Norway, and the list goes on, will live 2 to 3 years longer than Americans. So in terms of our outcomes, they're not particularly good. What about prescription drugs? Clearly, when we go to the doctors, very often the therapy is medicine. I recall talking to a doctor in northern Vermont who told me that about 25% of the patients that she sees, and when she writes prescriptions for, are unable to fill those prescriptions because they're just too expensive. The fact of the matter is the pharmaceutical industry in this country earns huge profits and charges our people the highest prices in the world for prescription drugs. There's a lot more to be said, but let me end my remarks with those comments, and I look forward to hearing the testimony of our esteemed panelists. Senator Burr.
Thank you, Mr. Chairman, and thank you for calling this hearing. I truly thank our witnesses today for their knowledge and for their willingness to be here to share with us their information. In about 2 weeks, our nation will mark the 4th anniversary of the enactment of the Affordable Care Act, better known to most as Obamacare. Today's hearing will inform what direction we will next take health care in America by examining access to care and cost associated with health care systems overseas. As we examine single-payer systems in other countries and what we can learn from their experiences, it seems fitting that we also take stock of where things stand in the American healthcare system today. At the time Obamacare was being debated in this very committee, I warned that it was the wrong direction for our country. Healthcare was broken before Obamacare, but 4 years later, the American people are experiencing firsthand how the new law has made things worse. That's why Americans view the law unfavorably. And that's why they are understandably wary of still more government involvement in health care. The President promised that if you like your plan, you get to keep it under Obamacare. The federal government mandates that Americans buy health care coverage, and not just any coverage, but the coverage the federal government says is good enough. Sadly, millions of Americans have lost their health care plans, health plans they liked and wanted to keep, despite the promises and continued delays of the administration. Obamacare expanded Medicaid, an unsustainable health entitlement program in which 40% of physicians on average do not even agree to see Medicaid patients. I believe the experiences of other countries will reinforce what many Medicaid patients already know. Their coverage does not always translate into timely access to care. Today's hearing will also examine cost. While the President promised that Obamacare would bring down premiums by $2,500, premiums have actually gone up by an average of 41% in the individual market due to the law's mandates. So, how does Obamacare attempt to control cost? For starters, it established the Independent Payment Advisory Board, or IPAB, an unelected, unaccountable board of 15 bureaucrats empowered to make cuts to the Medicare program, most likely in the form of cuts to doctors, which will impact, again, seniors' access to care. Today's hearing will be informative as to the direction we take health care in this country. Will we repeal Obamacare and replace it with reforms that lower health care costs, put our nation's entitlement programs on a sustainable path, and empower patients in their health care purchasing and decision-making to find the plans that best meet their individual needs? Or will we continue on the current course of unprecedented government involvement in health care and unsustainable costs? What do we have to learn from a single-payer system overseas, and what have other countries' reforms meant for their patients? What would such a course mean for our nation standing as a global leader in medical innovation and for American patients seeking access to quality and affordable coverage and care that meets their individual health care needs? I do want to thank Chairman Sanders for holding this hearing because it will inform many of us on these important questions. I think today's hearing represents an important admission that Obamacare is not working. That such an admission takes place within the very committee that the act was written in is a huge step, and I commend the committee for taking it. I look forward to hearing from our witnesses today and continuing to work with my colleagues to advance patient-centered reforms that will actually lower health care costs and increase access to quality, affordable health care. I thank the chair.
Thank you, Senator Burr. Senator Enzi, did you want to make a statement? Okay. Thank you. We have 7 very knowledgeable panelists, and we look forward to their testimony. We're going to ask you to keep your remarks to 5 minutes, and then we will follow up with some questions. Our first witness is Mei Cheng, a health policy research analyst at the Woodrow Wilson School of Public and International Affairs at Princeton University. Ms. Cheng is an advisor to the China National Health Development Research Center, and we very much appreciate her being with us today. Please speak right into that microphone so everyone can hear you. A little bit.
Oh, it's already started counting.
Get close to that mic.
Good morning, Mr. Chairman, Senator Sanders, Ranking Member Burr, and Senator Enzi. My name is Mei Cheng. I'm Health Policy Research Analyst at the Woodrow Wilson School of Public and International Affairs, Princeton University. Thank you for inviting me to testify. I have been asked to give an overview of single-payer systems, and I here distill my written testimony into a few salient points. An overarching point made in my testimony is that single-payer systems are not the same as socialized medicine or socialism, as is so often assumed in this country. In socialized medicine, government owns and operates the healthcare delivery system and finances it. The health system Americans reserve for their military veterans, for example, the VA system, is purely socialized medicine. Single-payer systems typically are just social insurance, like the Social Security system. Under social health insurance, the government merely organizes the financing of health care, but the healthcare delivery system typically is private and can include for-profit entities. Medicare, for example, the social insurance, it is social insurance, but not socialized medicine. The main characteristics of single-payer systems are the following. They are ideal platform for equity in access to health care because everyone has the same insurance coverage and providers are paid the same fees regardless of the socioeconomic status of the patient. Single-payer systems typically are financed on the basis of ability to pay rather than on the basis of health status of the insured. Single-payer systems typically give patients free choice of doctors and hospitals. In single-payer systems, providers of care do not compete on price, but they must compete on quality of care, including patient satisfaction. In a single-payer health insurance system, health insurance is not tied to a job. Instead, it is fully portable from job to job when people lose their job and in a retirement. Does not go away. Therefore, there's no job lock in these systems over health insurance. Because all funds to providers of healthcare in a single-payer system flow from one payer, it is relatively easy to control total health spending in such systems. The international data I cite in my written testimony make that clear. Now, some single-payer systems, like UK and Canada, may put constraints on the physical capacity of their health system, like number of hospitals and MRI scanners, as part of their effort to control total health spending, including waste created by excess capacity. This constraint may lead to rationing by the queue. The alternative to rationing by such administrative measures is rationing by price and ability to pay, something that we see in the U.S. healthcare system. The argument that healthcare is not rationed in the U.S. is not supported by the data. A single-payer system is an ideal platform for modern IT. With common nomenclature, all billing can be done electronically, and it yields enormous savings in administrative costs. And because such an IT system conveniently captures data and information on all healthcare transactions, these systems provide a database that can know spending in real time and is, as in the case of Taiwan, and it is a base for use for quality measurement, monitoring, and improvement. And public satisfaction about single-payer systems is generally high. Denmark, for example, is ranked the number 2 highest in the European Union in consumer satisfaction. In Taiwan, public satisfaction is also very high, with a national health insurance program ranging in the 70s to 80%. In Canada, a 2013 international survey of 11 countries found that 42% of Canadians surveyed said that their healthcare system works well and need only minor changes, compared to just 25% of Americans who said that. 75% of Americans said American healthcare system needs fundamental changes or completely rebuilt. Lastly, survey research has shown that single-payer Medicare is very popular in the U.S. A final point is that every health system has its flaws, which can be highlighted with anecdotes. Therefore, there's now a brisk medical tourism worldwide. For example, Canadians come to the U.S. for health care, but it also is true that Americans go to Canada, Mexico, Thailand, and Taiwan for lower-cost health care. Thank you very much.
Thank you, Ms. Cheng. We're going to go now to Dr. Rodwin. Victor G. Rodwin is a professor of health policy and management at New York University's Wagner School of Public Service. He has worked his entire career on studying healthcare systems abroad with a special focus on France. Professor Rodwin held the Fulbright Tocqueville Distinguished Chair at the University of Paris, Orsay, in 2010. Dr. Rodwin, thanks very much for being with us.
Thank you, Senator Sanders, and distinguished members of the committee. Good morning to all of you watching on C-SPAN. My name is Victor Rodwin. I will speak on the French healthcare system. That system is a model of national health insurance that provides healthcare coverage to all legal residents residing in France. It is not, I repeat, it is not an example of socialized medicine like Cuba. It is also not a national health service as in the United Kingdom. It is also not an instance of a government-run health system like our excellent Veterans Health Administration. French national health insurance, in contrast, is an example of public, social security, and private healthcare financing combined with a diverse public-private mix in the provision of healthcare services. The French healthcare system reflects three political values embraced by Americans. Liberalism, in the sense of giving patients free choice of any doctor or any hospital they care to go to, with no networks, no restrictions. Second, pluralism. Everybody has a diverse choice. They can go to fee-for-service solo practitioners, they can go to group practices, they can go to outpatient health centers, they can go to emergency rooms, they can go to public hospitals, private hospitals, outpatient consultations with specialists in public hospitals. The third value is solidarity, in the sense of having those with greater wealth and better health finance services for those who are less well off and in poorer health. Now, in terms of population health, the French outdo us, and I'm embarrassed to say that as an American, hands down. Look at any indicator you like. Life expectancy at birth, they do better than we do. Infant mortality, they do better than we do. Female life expectancy at 65, they outlive us. Female life expectancy at 80, or male life expectancy at 80 years of age, where medical care matters, they outdo us. Disability-adjusted life expectancy, which takes into account measures of disability, they outdo us. Years of life lost, we have more years of life lost. This is not a Republican or Democratic debate. These are the facts. But that's not the way to judge a healthcare system entirely. Surely a healthcare system reflects these indicators, but not just the healthcare system. My colleagues at NYU would still say that we have the best healthcare system in the world in spite of these indicators. They would argue that these indicators reflect other things for which they assume no responsibility. Social services, inequality of income, family policies, which are very strong in France, maternal and child health programs, all of which are factors which explain why they have better population health than we do. So we have to look at other indicators. And one important indicator of health system performance is called avoidable mortality. That is, in a good healthcare system, women should not die in childbirth. People should not die of tuberculosis. People should not die of ischemic heart disease. People should not die of cancers that can be cured. And when we look at that, I'm embarrassed to say that we come out in the United States as 19, and the French come out as number 1. I repeat, number 1. That is a fact that cannot be ignored. It must be addressed. It was written up in Health Affairs, a reputable journal. It was confirmed with different measures by the OECD, and it has not received, in my judgment, sufficient discussion. Another indicator of how well a system is doing, and a theme of this subcommittee that I know is dear to Chairman Sanders, is access to primary care. You can talk about primary care till you're blue in the face, but let's look at the consequences of whether you receive primary care or not in different healthcare systems. We have a very established measure of primary care access. It's very direct. If people end up in the hospital for conditions for which you should not have exacerbations if you have access to primary care, that's called avoidable hospitalization. And on that criterion, avoidable hospitalization, the rates of avoidable hospitalization are twice as high in the United States as they are in France. That's an unfortunate statistic from the point of view of an American, but that's the way it is. Lessons that we can draw. I believe that health systems cannot be transplanted from one country to another, but we can talk about some issues, and I'll just tick them off. I'll go over 30 seconds if you'll allow me, Mr. Chairman. In France, there's no choice of insurance plan. Everybody's in the same plan for the standardized benefits, but there's a complete choice of hospital or doctor. In France, all insurers, and there are more than one, pay the same price according to nationally set rates. You don't have a lower price for Medicaid, a higher price for Medicare, and even higher price for commercials. In France, there are no physician gatekeepers. Everybody can go where they like. No one's telling them what network they can or cannot go in. They don't have to call their insurance company to get authorization. In France, there's extensive co-insurance, small, but there's a voluntary health.
We're going to have to learn more about France in a few minutes. Senator Murphy, did you want to make a brief opening remark? No, okay. Let's go to Dr. Ye. If I'm pronouncing your name, forgive me if I'm not. Dr. Ye is a professor at the School of Public Health, Tsuchi University in Taiwan. And we very much appreciate your being with us today. Just speak closely into that microphone and tell us a little bit about what goes on in Taiwan.
Chairman Sanders, Senator Burr, and distinguished members of the committee, thank you for inviting me to testify here. My name is Jinchuan Ye. I'm the professor at the Tsuchi University, but I was the founding CEO of our National Health Insurance Administration in 1995 to 1998. That is 19 years ago. And I was the Minister of Health in Taiwan. And Taiwan established the Universal National Health Insurance in 1995. Currently, 99.6% of our population enroll in this program. The other 0.4% is they have citizenship but stay abroad. They are not covered. Taiwan's NHI program is a single-payer system and has a large single risk pool. Before that, we have 12 different social programs, strong and weak program, and we merge into one single pool. That enabled us to have cross-subsidization among the rich and poor, the well and the sick. Study shows that the premium contribution compared to the health resources utilized are favorable to the low and middle income. Having a single-payer system is the main reason for our efficient services and also how at the low prices of our health care we can achieve. We have a private, not-for-profit delivery system, and very highly competitive providers enable us to have efficient service. We contract 100% of the hospital in Taiwan and 93.5% of the private practitioner, and enable us, the insurer, if they have the car, they can go anywhere, any hospital, any private practitioner for seek the advice. And that enables us a very easy and equal access to the system. And single insurance administration have the benefit of very low administrative costs, which is only 1.15% of the total NHI spending. And people enjoy complete free choice of provider, and provider in Taiwan must be mindful of their patients' demand to stay competitive. Our satisfaction rate is, after 2 years of the implementation, it's always between 70 to 80%. We have a national fee schedule, uniform fee schedule. So the cost of the hospital and the provider can only compete on quality instead of price competition. And patient carry their insurance card can go to any provider if they are not satisfied with their quality of services. Basically, there are no waiting lists at all, except for a few well-known medical institutes or well-known doctors. And rationing is solved by provider competition and efficiency of our services. In 2012, our life expectancy, our infant mortality, our maternal mortality, and some clinical indicator, we are much better than U.S. Although we spend only 1/6 of the U.S. dollar, if PPP adjusted, it is 1/4 of the U.S. dollar we spend. But we are doing better than U.S. And last thing I wish to mention is our IT system, health information system. Everyone have this card, and with 6 last visit record in this card. But actually, all our provider submit their data electronically. So we are on the way to develop a closed system EMR. So we expect to accomplish a lifelong e-record for everyone in the next few years. I think my time is up. Thank you.
Thank you very much. Senator Roberts, did you want to make a brief opening remark?
No, sir. In the interest of time, I do have a question of the witnesses, but I'll wait.
Sure. Okay, we'll get to
time.
that.
Thank you, Mr.
Okay.
Chairman.
Thank you very much. Senator Burr, I think you have a panelist you want to introduce.
Thank you, Mr. Chairman, and I thank my colleagues. I have the pleasure of introducing to you today Ms. Sally Pipes, President, CEO, and Taub Fellow in Healthcare Studies at the Pacific Research Institute in San Francisco, California. Sally, thanks for joining us today to explore what we might learn from other countries around the world to improve our healthcare system here at home. As a native Canadian and naturalized American, Ms. Pipes has a unique understanding of how single-payer systems actually operate. Congratulations on becoming an American citizen. We're pleased to welcome you and look forward to hearing about your personal experiences and professional analysis of single-payer systems. The mic is yours, Sally.
Thank you, Chairman Sanders and Ranking Member Burr, for inviting me to testify today. I'm Sally Pipes, President of the Pacific Research Institute, a think tank based in San Francisco that's dedicated to advancing opportunity for all through market-based solutions. I'm going to focus my remarks today on Canada's single-payer Medicare for All system, a system with which I am extremely familiar, as I am, as Senator Burr said, a native of Canada. Many healthcare reform advocates point to Canada as a shining example of advantages of a state-run single-payer system. Canada is in fact one of only a handful of countries with a bona fide single-payer system. Government officials set the budget for what can be spent on healthcare every year. Provinces administer their own insurance programs with additional funding from the federal government. Private insurance is outlawed in many provinces. This is the sort of system that many are calling for here in the United States. They want to abolish private insurance and leave government as the sole source of health coverage. But the Canadian system is one that would not be suitable for America. Officials severely restrict patient access to care, and those restrictions saddle patients and their families with massive monetary and non-monetary costs. Or to frame this in terms of the title of this hearing, if you're looking for lessons from healthcare systems abroad, Canada shows us exactly what not to do. Let's start with wait times. In order to keep a lid on healthcare costs, Canadian officials have to ration care. According to Canada's Fraser Institute, the average Canadian has to wait over 18 weeks from seeing a primary care doctor to getting treatment by a specialist. And wait times are only growing. The 18-week delay today plaguing Canadians is 91% higher than it was in 1993. At any given time, 17% of the Canadian population, 5 million out of 35 million, are on a waiting list to get primary care. There's also a severe shortage of essential medical equipment. For instance, Canada ranks 14th out of 23 OECD countries in MRI machines per million people, with an average wait time at just over 8 weeks. These lengthy waits have profound consequences, not just for patients who are suffering, but the rest of society. When people aren't treated in a timely fashion, their conditions worsen and their health deteriorates. Their productivity drops and they may have to stop work entirely. And they often end up requiring significantly more expensive and extensive treatments, which are costly for the entire system. One estimate from the Center for Spatial Economics found that wait times for just 4 key procedures, MRI scans and surgeries for joint replacement, cataracts, and coronary artery bypass grafts cost Canadian patients $14.8 billion every year in excess medical costs and lost productivity. Once Canadian patients finally receive medical treatment, it is far from free. About 68 cents out of every dollar in government revenue goes to healthcare spending. But the typical Canadian family spends about $11,300 in taxes every year just to finance the public system. Technically, every Canadian has access to needed healthcare services. In 2005, Madam Chief Justice Beverly McLaughlin of the Canadian Supreme Court ruled in favor of overturning the ban on private health coverage in Quebec. She wrote that access to a waiting list is not access to health care. Those Canadians who can afford to opt out often come to the United States. About 42,000 Canadians come every year to this country to pay out of pocket. Danny Williams, former Premier of Newfoundland, in 2010 flew to Florida for heart valve surgery. When questioned by the press about that decision, he said, "It's my heart, it's my health, it's my choice. I did not sign away the right to get the best possible health care for myself when I entered politics." Brian Day, an orthopedic surgeon who runs an illegal clinic in Vancouver, said a person can get a hip replacement for their dog in less than a week. For a Canadian, it's over 2 years. My own mother died from colon cancer because she had to wait. She could not get a colonoscopy. When she had lost 35 pounds 4 months later, she entered the hospital, had a colonoscopy, died 2 weeks later from metastasized colon cancer. How much longer could we have had my mother if she had had prompt treatment? There is an example in the U.S. of a single-payer system. It's the VA, and there's a lot of dissatisfaction with waiting lists. I think this is no way for us to run a healthcare system, a single-payer system. We need a new way to inject genuine market competition and clinic and choice into our healthcare system. We need to scale back top-down controls by government. Thank you, and I look forward to your questions.
Okay. Thank you very much, Ms. Pipes. Turns out we have another Canadian with us as well. Our fourth witness is Dr. Danielle Martin, a primary care family physician actively involved in practice at Women's College Hospital in Toronto, Canada, where she also holds an administrative leadership position as Vice President of Medical Affairs and Health Systems Solutions. Dr. Martin, thank you very much for being with us.
Chairman Sanders, Ranking Member Burr, distinguished committee members, thank you for inviting me to address you today. My name is Danielle Martin. As a practicing physician and Vice President Medical Affairs and Health System Solutions at Women's College Hospital, I have daily first-hand experience with the Canadian single-payer system. In addition to my clinical training, I also hold a master's in public policy from the University of Toronto, where I'm currently an assistant professor. I do not presume to claim today that the Canadian system is perfect, or that we do not face significant challenges. The evidence is clear. The evidence is clear that those challenges do not stem from the single-payer nature of our system. Quite the contrary. Working within a public insurance structure helps us to better tackle many of the challenges shared by all developed nations in healthcare, including rising costs, variations in quality, and inequities of access. I would like to highlight for you today 3 major benefits of the Canadian single-payer model. The first is equity. Poll after poll has demonstrated a strong consensus among Canadians that access to health care should be based on need, not ability to pay. While, of course, we continue to struggle with inequity on other fronts, it is worth emphasizing that at substantially lower cost than in the U.S., all Canadians have insurance that covers doctor and hospital care. We do not have uninsured residents. We do not have different qualities of insurance depending on a person's employment. We do not have an industry working to try to carve out different niches of the risk pool. This is a very important accomplishment, And as we watch the debate unfold in the U.S. as to how to address the challenges you face, we are reminded daily of its significance. One of the big challenges in a multi-payer system is the question of how to achieve policy reform with so many players in the game. In a single-payer framework, if government and providers identify a significant challenge in the healthcare system, they can work together at the bargaining table to align financial incentives to advance their shared policy objectives. An example upon which I elaborate in my written submission is the way in which Ontario's government and physicians have worked together to increase the number of medical students choosing primary care as a career and choosing to work in rural underserviced communities. Finally, one cannot speak about single-payer without addressing the issue of administrative costs. It has been estimated that if U.S. administrative costs were curtailed to the level of those in my home province of Ontario, the total estimated savings here would be $27.6 billion per year. Indeed, overall, as you've heard, we spend a much lower proportion of our GDP on healthcare in Canada, 11.2% as compared to your 17.9%. And importantly, this is not at the expense of quality. Canadians enjoy the same or better health outcomes as Americans, both at the level of life expectancy and infant mortality, as you've heard, and when we look at outcomes for a range of acute and chronic illnesses. In fact, a recent scientific systematic review found that Canada achieved health outcomes that are at least equal to those in the United States at 2/3 of the cost across a very wide range of diagnoses. The issue of wait times is very widely covered, I note, in American media. When it comes to urgent and emergent care, Canadians are not waiting substantially longer than our peers in other countries, including the United States. Unfortunately, it is true that that has not been the case for elective medical care, such as non-urgent diagnostic imaging and elective surgeries. A great deal of work is underway to address this challenge, and indeed waits have been decreasing over the last decade for a variety of elective medical procedures. It is important to note that moving away from a single-payer model would likely exacerbate our wait time challenge rather than alleviating it by drawing critical health human resources out of the public system. This is borne out by international evidence from other jurisdictions such as Australia. The Canadian system is proof that public health care insurance need not be provided federally in order to achieve the benefits of the single-payer model. In Canada, each province provides public health care insurance to its residents with minimum standards set at the federal level. Furthermore, moving to single-payer insurance, as you've heard, does not necessarily mean moving to the direct provision of health care services by government or socialized medicine. Although our provincial health insurance plans in Canada are financed publicly, almost all health care services are delivered by private entities. This includes our hospitals, which are mostly independent, not-for-profit entities, and also our providers, most notably physicians, who are not employees of the state, but rather independent contractors who happen to bill a public insurance plan for their services. I want to reiterate my thanks to the committee for giving me the opportunity to present to you today. I look forward to your questions and engaging in dialogue.
Dr. Martin, thank you very much. Senator Byrd, do you want to introduce your other guest?
Thank you, Mr. Chairman. I'd like to introduce to my colleagues Dr. David, is it Hochberg? Good. Who's the Healthcare Policy Analyst at the National Center for Public Policy Research here in Washington, D.C. Dr. Hochberg, thank you for joining us today. I look forward to your testimony and thoughts as we examine the lessons learned from other abroad countries in order to strengthen our own healthcare system here at home. The mic is yours.
Chairman Sanders, Ranking Member Burr, members of the committee, thank you for this opportunity to testify before you. My name is David Hochberg, and I am a healthcare policy analyst for the National Center for Public Policy Research. I think the most important lesson we can learn from other nations is that we should avoid putting more and more of our healthcare system under the control of politicians. Most politicians want to get reelected, and that fact will have a substantial impact on healthcare policy. Groups that have political clout that can influence a politician's re-election chances are more likely to get good treatment under government-run healthcare systems. Groups that lack such clout are more likely to be neglected by politicians and receive inferior care. People who are very ill usually lack such political clout. First, the very sick are relatively few in number, which means they amount to a very limited number of voters, too limited to have much impact on elections. Second, they are too sick to engage in the type of political activities such as organizing, protesting, and so forth that can bring about change in healthcare policy. Ultimately, under a government system, those with the most medical need are those most likely to have difficulty getting the care they need. Both Denmark and France provide good examples of this. The healthcare system in Denmark could be best described as single-payer, with the government financing over 85% of healthcare expenditures. Healthcare in Denmark is largely free at the point of consumption. This has consequences for how healthcare resources are allocated. If patients pay nothing at the point of consumption, then patients will overuse healthcare, putting strain on government budgets. Healthcare must be rationed in another manner. And like most systems that are single-payer, Denmark rations by using wait times for treatment of serious conditions. For example, Danes must wait a median of 48 days to get a herniated disc repaired, 57 days for a knee replacement, and 81 days for cataracts treatment. Under the national standard for cancer treatment in Denmark, a patient should not wait more than 28 days between the time he sees a physician for diagnosis to the time of treatment. However, a 2010 study found that less than half of Danish patients diagnosed with head or neck cancer were treated within that national standard. This can have serious consequences for patients. A meta-analysis found that for every month treatment is delayed for head or neck cancer, the probability that the cancer will recur increases by about 3.7%. Now, looking to the French system, the healthcare system in France is financed heavily through the government, yet also has an extensive market of private insurance that covers co-payments and services the government does not cover. When a patient visits a physician in France, he must pay the cost directly. He is then reimbursed by the government and the private insurer. The patient must cover any cost that is not reimbursed. The method of payment and the extensive system of private finance is what allows France to avoid using wait times to ration care. However, the healthcare portion of France's budget has been running a deficit since 1988. As a result, the healthcare system in France has used other methods to ration care. One rationing method is limiting investment in new medical technology. Among industrialized nations, France has one of the lowest number of CAT scanners, PET scanners, and MRI machines per million population. Rationing pharmaceuticals is another method. In brief, the French government often refuses to pay for drugs that are incremental improvements over existing drugs. Such rationing has consequences. According to one study, only about 1/4 to 1/3 of Alzheimer's patients in France are receiving state-of-the-art medication. Rationing technology and medication, or using waiting times, falls hardest on people with serious illnesses. Yet these methods persist because they are politically tolerable. In general, they do not cause trouble for politicians, since the people affected seldom are a significant political force. In summary, I think the chief benefit of an examination of other nations' healthcare systems is to discover what policies we should avoid. That said, it would be far more productive if we instead studied other markets rather than other nations. That would include other markets for insurance, such as life, homeowners, and auto insurance, and other markets for other vital products, such as food and clothing. There you will find markets in which government tax policy hasn't distorted the purchase of goods, where tax policy and regulation have not resulted in a three-tiered system of insurance, and where consumers are not prohibited from buying goods and services out of state. As a result, these markets reduce the cost of goods and services while also improving quality. It is in these markets that we should look for guidance in reforming the U.S. healthcare system. Thank you very much.
Thank you very much, Dr. Hogberger. Our last but not least witness is Jacob Kjellberg. Dr. Kjellberg is a professor and program director for health at KORA, the Danish Institute for Local and Regional Government Research. Mr. Kjellberg, thank you very much for being with us.
Thank you, Chairman Sanders and Ranking Member Burr, members of the committee. I would like to thank you for the opportunity to participate in this hearing. I've been asked to give an overview of the Danish healthcare system. The Danish healthcare system is an example of a health system providing comprehensive and universal coverage for all patients. No patients may be denied services on the basis of income, employment status, age, or health status. Most patients in Denmark are listed with a GP of their choice. all visits to the GP are free, and the use of all specialized health services is free with a referral from the GP. Patient can also choose Group 2 health insurance and access specialist treatment directly. But a Group 2 patient will face a co-payment for visits to GP and specialists practicing outside the hospitals. Only about 1% of the population have chosen Group 2 health insurance, and people are generally quite satisfied with the GP system. If referred to a hospital treatment, patient may choose among all public hospitals offering the relevant treatment. All hospital treatment is free, including all hospital drugs. Patient may all choose among private hospitals in Denmark or hospitals abroad if the waiting time exceeds 1 or 2 months, depending on the severity of the condition. Many patients prefer to stay with the local hospital, therefore median waits can't be longer than the waiting time guarantee, but it's a choice. If cancer is suspected, we now offer a 2-week waiting time guarantee for examination and treatment. It had previously been a problem, as you mentioned. To finance the healthcare system, the state collects the necessary revenue through general taxation. The state funds the regions, and they on basis of objective criteria. This ensures equal opportunities for the regions across the country. The simplicity of the financing structure also keeps the administrative cost low. Only 4.3% of the total health spending is used for administration. The public sector finances about 85% of the total health expenditure. The 15% private expenditure mainly covers out-of-pocket payments for primary sector pharmaceuticals, dentistry, and optical services like glasses and contact lenses. About half of the population has supplementary health insurance to cover the out-of-pocket payments. There are also other supplementary health insurances where you can access healthcare quicker than the 1 month or 2 month waiting time guarantee or free access to physiotherapist. But the supplementary health insurances covers less than 1% of the total healthcare budget, but it's a choice. The health status in Denmark can generally be characterized by it being good. Surveys showed that 85% of the population perceive their own health status as excellent or very good. The life expectancy is on average 80.1 years. Historic high smoking rates is typically blamed for the relatively low life expectancy in Denmark compared to the other Nordic countries, not the system or the health system. The European consumer powerhouse ranks all the European healthcare systems, and here the Danish healthcare system ranks second in Europe. Denmark scores especially high on patient rights, range and reach of services provided, and information. Denmark scores relatively low in prevention and health outcome disciplines. Health expenditure in Denmark is slightly above OECD average when you look at the statistics. However, Denmark has a practice of reporting certain expenses for social care as health expenditures. If these costs were reported in line with the practice used in most other countries, the Danish health expenditure is significantly below OECD average. To sum up, the Danish healthcare system is an example of a transparent healthcare system that provides comprehensive and universal coverage and high level of patient satisfaction. The simplicity of the system keeps low cost and makes it easy for the patient to access health care. I would be happy to answer any questions you might have. Thank you for the attention.
Thank you very much, Mr. Kjellberg. Now we'll begin with questions and comments, and let me begin. Let me begin by asking all of our distinguished panelists a very simple question. In the United States today, we are the only nation in the industrialized world that does not guarantee people health care as a right. And we still have, well, the numbers have gone down since the Affordable Care Act, but we still have many, many millions of people who have no health insurance at all. Others have high co-payments or deductibles. So let me ask all of the panelists a very simple question. Should health care be a right of all people, regardless of income? Yes, no, maybe. Ms. Cheng, should health care be a right of all people?
I think it should. I think it should because it is a It is a sign and expression of a civil society.
Okay, I'm going to ask for brief answers. Dr. Ye?
Yeah, access to health care regardless of their job, their income, is an inalienable right in our Constitution.
Okay. Ms. Pipes?
No. We're entitled to life, liberty, and the pursuit of happiness. How do you determine which right is worth more? Do we have a right to housing, a right to food, a right to health care? How do you measure which is the appropriate level? So, no.
Okay, thank you. Dr. Martin?
Yes, access to health care is a human right, and I know that the vast majority of Canadians in poll after poll feel the same way.
Mr. Kelberg?
Yes, I believe that access to healthcare should be a right.
Dr. Hogberg?
Yes, I think it should be a right in the classical liberal notion of rights, that government should not interfere, Congress should make no law, and so forth. So yes, everyone should have the right to health care in that sense.
Dr. Rodin?
We have a right for health care in the United States for emergency care. I believe that should be extended to primary care as well.
Okay. Let me stay on that point, maybe get to Dr. Hoberg. You indicated that you thought health care should be a right, but government should not be involved in that process. Does that suggest that you would do away with the government-run Medicare program?
It's a moot point.
No, it's not.
It's a very moot point because seniors vote at very, very high rates, and we're not getting rid of Medicare. It's an academic
But I'm
question.
asking you as an academic. You're not, seniors do want it, you're right, it's a popular program. But if you say government should not be involved in health care, and Medicare is a government health care program, in your judgment, in the best of all your possible worlds, should we vote to get rid of Medicare? Some people think we should. What do you think?
I think it's a moot point. It's here to stay.
Well, I think you didn't answer my question. Ms. Pipes, I would like to ask you that question.
I believe that we are not going to get rid of Medicare. Medicare is a program for our seniors. I think we do have severe problems. The Medicare trustees have said that Medicare will be bankrupt by 2024, at a cost of over $1 trillion.
I just wanted to ask you a simple question.
It should be
Medicare is a government-run program.
Right.
As Dr. Hoberg indicated, I think it's a popular program. We could disagree. We have disagreements. My question is, should, in your judgment, we abolish this government-run Medicare program?
Not entirely. Medicare should be there for those people who truly need it. The problem is...
Truly need it, but
Right.
not as it is right now.
Because a lot of people are wealthy, can afford care, and they're
Well, not a lot of
putting
people are
cost
wealthy.
pressure
All right.
on the system. Paul
Okay.
Ryan,
Let me ask-
Congressman Ryan, I think has some very good ideas on
Right, and he would
premium support,
transform
changing the
Medicare
age.
into a voucher program. Dr. Rodman, let me ask you a question. Despite the fact that our health care outcomes are not particularly good, in terms of infant mortality, in terms of life expectancy, the United States ends up spending almost twice as much money per person on health care as any other nation. Why is that? And I'm going to give you, and we'll give Senator Burr additional time as well. Dr. Rodman, why is that? Put your mic up.
We spend more, Senator Sanders, for several reasons. First, our prices are higher than all other wealthy OECD nations.
All right, if a woman has a birth in this country compared to France, how much more does it cost? Or give me some examples.
It can cost different prices here depending on who insures you. It can range from the $5,000 to $27,000. The figures are in the excellent paper by Mei Chen from OECD for all to see. So price is one very, very important phenomenon. Prices of drugs, prices of...
How do drug prices compare in the United States compared to other countries?
In the aggregate, they are much higher. Much
Why
higher.
is that?
Why is that?
Yeah.
Because we have no price control.
So if I need a cancer drug in the United States, Why is it much more expensive here than it is in Canada or in France?
In Canada and in France, you have regulated prices for these drugs, and people have access to them. In France,
That interferes with the free market system. Is that a good idea?
of course it's a good idea. The free market system doesn't exist anywhere in healthcare. I challenge anyone to give me one example of a free market system that is operational and works. It's a fine idea in theory, but I challenge anyone to give me one concrete example. All the evidence suggests that it does not work.
Okay, Senator Burr.
Dr. Martin, in your testimony, you note that Canadian doctors exiting the public system for the private sector has had the effect of increasing waiting lists for patients seeking public health care. Why are doctors exiting the public system in Canada?
Thank you for your question, Senator. If I didn't express myself in a way that to make myself understood, I apologize. There are no doctors exiting the public system in Canada, and in fact, we see a net influx of physicians from the United States into the Canadian system over the last number of years. What I did say was that the solution to the wait time challenge that we have in Canada, which we do have a difficult time with waits for elective medical procedures, does not lie in moving away from our single payer system towards a multi-payer system. And that's borne out by the experience of Australia. So Australia used to have a single tier system, and in the 1990s moved to a multiple payer system where private insurance was permitted. And a very well-known study by Duckett et al. Was tracked what took place in terms of wait times in Australia as the multi-payer system was put in place. And what they found was, in those areas of Australia where private insurance was being taken up and utilized, waits in the public system became longer.
What do you say to an elected official who goes to Florida and not the Canadian system to have a heart valve replaced?
It's actually interesting because, in fact, the people who are the pioneers of that particular surgery, which Premier Williams had, and had the best health outcomes in the world for that surgery, are in Toronto at the Peter Monk Cardiac Centre, just down the street from where I work. So what I say is that sometimes people have a perception, and I believe that actually this is fueled in part by media discourse, that going to where you pay more for something, that necessarily makes it better, but it's not actually borne out by the evidence on outcomes from that cardiac surgery or any other.
One would believe the American people prefer their system because they know consciously they pay more. No, I think it's because they judge quality and they judge innovation. Ms. Pipes, in your testimony, you noted that more than 42,000 Canadians come to the United States each year for health care. Why is that?
Because they find that they're on a waiting list in Canada for too long a period, and they feel that their health is at stake. So a lot of people in Canada come to the U.S. for MRIs, CT scans. There are many examples in the media of people like Brian McCreath, who came to the U.S. because he was told by his primary care doctor that he might have a brain tumor, but the wait for an MRI was very long. He spent the $1,000, came to the U.S., paid out of pocket. You will see advertisements in Canadian newspapers for MRIs, for neurosurgery.
It's a pretty fertile ground to market in.
Right.
Dr. Martin, in your testimony, you state that the focus should be on reducing waiting times in a way that's equitable for all. What length of time do you consider to be equitable when waiting for care?
Well, in fact, the Wait Time Alliance in Canada, sir, has established benchmarks across a variety of different diagnoses for what's a reasonable period to wait. And what we've found is that actually working within the single payer system, we can reorganize things. You know, I waited more than 30 minutes at the security line to get into this building today. And when I arrived in the lobby, I noticed across the hall that there was a second entry point with no lineup whatsoever. Sometimes it's not actually about the amount of resources that you have, but rather about how you organize people in order to use your queues most effectively. And that's what we're working to do, because we believe that when you try to address wait times, you should do it in a way that benefits everyone, not just people who can afford to pay.
On average, how many Canadian patients on a waiting list die each year? Do you know?
I don't, sir, but I know that there are 45,000 in America who die waiting because they don't have insurance at all.
Well, let me go back to Dr. Rodwin's statement. The American system has access to health care for everybody. It's called the emergency room. Now, we don't admit that clearly because we're lobbying for a particular angle. But every American can access health care. They can access primary care, And Dr. Rodwin, I would agree with you that we ought to make sure that there's a medical home for practically everybody we can place. We don't do it in Medicaid. We should. States should adopt it because primary care is an absolute necessity to wellness. But, Mr. Kelberg, how many Danish citizens have supplemental health insurance policies, and why has that number been increasing in recent years?
About half the population got co-payment insurance, and that have increased dramatically over the last year because the family were included, so children were included, and that brought up the numbers quite significantly. But the number for policyholders haven't really changed much.
But half the population has supplemental insurance.
Co-payment insurance. And then many people in the labor market also, as part of a benefit package, are offered health insurance so you can have faster access to elective care.
So they can actually buy their way to faster access.
Oh, you can buy that. There are private hospitals. You can buy any hospital services in Denmark.
So they have options. They have choices.
They have choice, yeah.
Dr. Rodwin, in your testimony, you note that Parliament sets healthcare expenditure targets each year. If a hospital or a physician exceeds their target expenditure by billing for higher than projected volume of services, prices are negotiated downward for the following year. Beyond volume or utilization of services, are there quality metrics that the French use to determine reimbursement for physicians or other providers in order to incentivize quality care for patients? For example, measuring health outcomes to ensure patients are receiving quality care.
This is a science that's not well developed neither in our country nor in France, but they are working on this very question, which is very timely, right now. That is, the negotiations focus certainly on volume, but now there's a program called IFAC, which will remunerate physicians. Well, that's actually already in place if they follow certain standards of preventive care.
But they're penalized if they bill at a higher rate one year. They're penalized in the next year by a reduction in the reimbursement.
Every year, sir, there's a negotiation to set these rates, and if the volume goes up, then the following year, the prices, that's the practice, it's the volume health performance standard.
Thank you, Doctor.
Yes, it's a
Thank you, Mr. Chairman.
budget target.
Senator Nancy.
Thank you, Mr. Chairman, and I want to thank the distinguished panel for all of the information that they've provided. It's a little different than a session that Senator Kennedy and I held several years ago, but first of all, I want to thank Ms. Pipes for being here. She wrote a book in 2010 that predicted what was going to happen with our health care system as it is now. And then more recently, she's written something called The Cure for Obamacare, and it's not even copyrighted, but it's an outstanding book on what we could do to repair the damage that's been done on our present system. And I thank you for your effort on that and hope I can get a few more people to read them. I mentioned Senator Kennedy and I, when I was the chairman and he was the ranking member, we went to a system called a roundtable, and this is very similar, except that at a roundtable we had, again, 8 to 10 people, and they were all practitioners of some sort in the healthcare area rather than people who were studying the healthcare system. And he and I would come up with the questions for the panel, as well as total agreement on who should serve on it, as opposed to the way we do panels now, which is the chairman gets to pick everybody, 4/5 of every panel, and the ranking member gets to pick another 1 or 2, and then we all come and beat up on the witnesses. So at a round table, the senators really didn't speak much, but one of the questions we asked is, will universal single-pay health care work in America? And the first person was an engineer for hospitals, and he wasn't sure. But the other practitioners all said, America won't settle for universal single-pay health care. At the end of that hearing, that roundtable, Senator Kennedy came to me and he said, I guess we better take a look at some of the things you've suggested, like small business health plans and being able to sell across state lines and things like that. And I think one of the things that this panel points out, most of you are talking about countries whose population is and size in some cases is relative to our states, each state. And in the United States, each state has health care plans. And they do it differently. And as the chairman mentioned, some of them have good ideas and those spread to others. But what will work in Canada with a smaller population, or Denmark with a smaller population, or France with a smaller population, might not work in the United States, especially under the form of government that we've got. I'm pretty sure that the Affordable Health Care initiative was designed to fail. That was predicted by Senator Graham about 15 years ago, and he thought that they would come up with a system that would fail, and then we could go to universal single-pay health care. I think that would have worked, except for one thing. The debacle with the design of the exchange reminded people in America what happens when our federal government tries to handle everything for this vast United States with one plan. And of course, I'm on the Homeland Security Committee too, and we're trying to work with another one of those government agencies that's called the Post Office. And that's another example that people use of what might happen if we went to universal single-pay health care. I've been to some countries that have a lot of population, like India, and they're very proud of their system. I asked how they took care of that vast of a population, and they said, well, our doctors see 200 patients a day. I don't think our doctors see 200 patients a day and wouldn't take that quick of action. The question of Medicare that was asked earlier, if people were given another option, I think they'd go with another option. Too many people in America right now that are seniors at least know somebody that tried to see a doctor and the doctor said, I'm not seeing any Medicare patients. So Medicare is not the best example of how to get health care in America. And I've almost used up my time without asking a question. I'm the accountant on the panel. In fact, I'm one of 3 accountants in the United States Senate. And so the questions that I have are really kind of technical and get down to some of the costs. And so I'll submit those in writing and would appreciate it if you'd answer the questions. Thank you. Thank you, Mr. Chairman.
Thank you very much, Senator Enzi. Senator Roberts.
Well, I too want to thank the panel, and thank you, Mr. Chairman, for holding this hearing. It seems to me that the entire question here has been summed up by the chairman. Does the government, if we have a government guarantee of health care as a right, he posed that question. And then with questions, Senator Enzi and Senator Burr have pointed out, or is it a right to a waiting list? Actually, I think that is the statement by Ms. Pipes. And Ms. Pipes, my deep regrets for the loss of your mother. How long did she have to wait?
She went to her primary care doctor, her general practitioner, we call him, in June, and she was admitted to Vancouver General Hospital, which is one of the largest hospitals in Canada, in late November. Late November.
And then you lost her after 2 weeks. Did you say that you could get a hip replacement for a dog in a week, but you couldn't get a hip replacement for an individual for X number of weeks?
2 years. Yes, the wait for orthopedics is one of the longest waits in Canada, and my friend Dr. Brian Day, who's an orthopedic surgeon in Vancouver, made that statement to the New York Times. Dr. Day, who runs the Canby Clinic, is being sued by the British Columbia government for operating a clinic which is considered illegal in British Columbia. The interesting thing is, he told me the other day, the government keeps postponing the case, and I think it's because his practice is so busy with people getting hip replacements, knee replacements, that they're afraid of the backlash that will happen because of that.
I have legislation that I call the Four Rationers Repeal Bill. I'm not going to get into the four rationing boards, IPAB, CER, et cetera, to address some of my concerns about the government controls and where we are with the Affordable Health Care Act. I'm trying to get ahead of that curve. By the way, I don't know, Dr. Martin, does Prime Minister Harper, does he change the rules and delay implementation of the system every week like we see going on with the Affordable Health Care Act?
I'm not sure that that you want me to answer that question, sir. I don't completely understand what you're saying, but...
Well, I'm saying that the Prime Minister of Canada, I don't think changes the National Health Care Act that we have in place, which I think is basically a first step toward single payer, and I think that was the intent of it. The President of the United States has changed the health care. About every Friday we have what we call a regulation dump, okay? A consortium of unions indicated that they would like a big change in the Affordable Health Care Act. He's going to have a carve-out for them. On the other side of the fence, 27 members of the Finance Committee, some on this committee, wrote to Marilyn Tavender, the head of the Centers of Medicare and Medicaid Services, to say, whoa, don't change the Medicare D program that we have in this country, a very popular program under budget, used by a great number of our senior citizens. And if we hadn't written the letter and if there hadn't been a real backlash from the people to save Medicare Part D, it wouldn't have happened. So we're just sort of writing this thing as we go along, except the President doesn't come to us and ask us to help him do that with each individual change. I'm just wondering, with the problems you have up in Canada, who makes the change, if in fact there needs to be a change?
Well, I suppose the answer to your question comes in two parts. The first is in acknowledgement, I think, of what Senator Enzi was saying earlier on, which is that like the United States, Canada is a huge country, and our health insurance is actually not provided at the national or federal level. It's provided at the provincial level or the equivalent of your states. And so the notion that something can begin in one subnational jurisdiction and then spread is in fact exactly how we came to have 13 separate single-payer systems in the 13 provinces and territories of Canada. And so the first part of the answer to your question is no, we don't see that kind of those kinds of changes being made to healthcare legislation at the national level. But the second part of the answer to your question is that it is widely known in Canada that the public commitment to our single-payer Medicare system is so strong that for a Prime Minister of any political stripe to try to alter that and undermine it in any way would be political suicide.
I got your message. Dr. Holberg, you mentioned the fact we ought to keep the politicians out, and we've just had two changes, Medicare Part D and then also a carve-out for the unions. Is that an example of what we're talking about? And 33 other changes, by the way, and that's the last count that I have.
Well, I mean, they're very good examples of groups that have political clout can keep changes from happening that they don't want to see. Unions and seniors certainly have plenty of clout up here on Capitol Hill. And if would you mind if I would just take a second to talk about some of the outcome measures here?
Well, I'm already over time, 23
okay.
seconds. I'll ask the permission of the chairman if that would be possible.
Take another 30 seconds.
All right, thank you, sir. You got 30 seconds.
Yeah, first of all, with regard to life expectancy and infant mortality, using those as measures of to tell you something about a healthcare system is a bit like using batting average and on-base percentage to tell you something about football. Life expectancy and infant mortality, there are so many factors that go into those outcomes that are not related to the healthcare system, that the healthcare system has no control over, that they are really not good measures for telling you the quality of a healthcare system. One other problem is that many of these measures are not measured the same from country to country, infant mortality being the...
Well, thank you for that. The chairman's already hit the gavel. My main question is access to care and denial of that care, and what other alternative a person has with the single-payer system.
Okay, Senator, we're going to have another round of questions. This is a great panel. I think they're good questions. But let me pick up on a point. That's my turn now. Pick up on a point that Dr. Martin raised, because I was going to ask the same question. I live 1 hour away from the Canadian border. Canadians watch American television. Canadians are very familiar with our political system, probably know more about politics in America than most Americans know. Is your Prime Minister a socialist?
No, sir, our Prime Minister is quite conservative. He's the leader.
Conservative?
Yes, indeed.
So obviously, as a conservative, he wants to implement the American healthcare system that the Canadians are very aware of. I gather that was probably the first thing he did when he took power. Is that right?
Not exactly.
Why not?
Support for single-payer Medicare in Canada goes across all political stripes. Quite famously, we had the leader of the most right-wing party in a Canadian federal debate on television hold up a sign in the middle of the debate on which he'd written in marker, "No two-tier," as a means of trying to reassure the Canadian public that if elected, he would not dismantle the
In other words,
system.
you have a nation bordering on the United States, two nations that are probably as close together in so many respects as any two nations in the world, a conservative prime minister, and yet there is no effort to move to an American healthcare system. I would say to my colleagues, there's not a better example of maybe how people feel about two systems. They know the American system. They have a conservative prime minister. They can move in our direction, but for whatever reason, and I think sensible reasons, they understand that a system that guarantees health care to all of their people in a cost-effective way is the way that they want to stay. Ms. Pipes, let me ask you that question. Why do the Canadians not come to the American health care system?
Well, as I mentioned in my testimony, about 42,000 Canadians every year come to the U.S. and pay out of pocket for assistance.
That wasn't my question.
No, I just made that. I wanted to make that point first. Second, the Canadian government and the provinces who administer the Canadian healthcare system, this started in 1974. A lot of people in Canada have no idea of an alternative system.
Oh, my goodness.
No.
They live an hour away from me in Burlington, Vermont. They watch American television. They read American newspapers. They have no idea of what goes on in the United States of America. That is a little bit hard for me to believe.
I would say that Canadian people are very, very nice people. They're not impatient like Americans. My mother said to me, I hope you're not becoming an impatient American. I am an impatient American. Americans do not want to wait. Canadians are very nice.
Well,
the doctor says, and then the second...
Ms. Pipes, I have a limited time.
Yes.
I think the answer is pretty clear. The Canadians have seen the American system. They prefer their own. Now, I want to say a word about access, because and waiting lists. Senator Roberts raised that issue, and Senator Byrd did. I want to focus on that picture over there. I know it's hard to believe, and I mean this quite seriously. This is the United States of America. This is not a third world developing country. This is a town called Wise, Virginia, and I don't mean to pick on Virginia, because I think the same story can be told all over America. So when we talk about access, what we're looking at here is that a number of times a year, people, working class people, who have no health insurance at all, are given free health care, episodic care. Volunteer doctors very kindly come, and in a day, thousands of people line up because this is the health care they get. This takes place in a field in Wise, Virginia. I think it's a stadium in Los Angeles where something similar takes place. Now, if this is the kind of health care that we are proud of in the United States of America, well, some of us have some strong disagreements about that. Dr. Rodwin, I want to get back to another point, which to me is very important. It is, and I'd like Dr. Martin to comment on this as well, and maybe Dr. Ye and Ms. Cheng. To get good health care, you need medicine very often. If I go into a French hospital, I leave the hospital and I'm sick, how much does my medicine cost?
Under French national health insurance, there's very high levels of pharmaceutical coverage.
Meaning what? My medicine is free or virtually free?
Virtually free, 90%, 80%, 70%.
Right, Dr. Martin?
Those prescription drugs that are cut because they're ineffective.
Okay. Dr. Martin?
So interestingly, this is an area where we made a mistake in the design of our single-payer program in Canada. At the time that Canadian Medicare was designed in the 1950s and 60s, medication was not a really big part of the way that we treated disease, and medicines were left out of coverage. So the single-payer program in Canada does not include medications, and as a result, 1 in 10 Canadians today fails to fill a prescription or take their medicine as prescribed because of concerns about cost.
Thank you. Mr. Kjellberg, what about prescription drugs in Denmark?
All hospital use at hospital are free of charge, and if prescription drugs are needed, you have a maximum co-payment a year about $600.
Okay. Dr. Ye, in Taiwan, how much do prescription drugs cost?
It is covered by the NHI, but patient had to pay some copayment up to the ceiling of about the $10 US.
10 up to $10 US?
Up to 10. And each year add up to be the ceiling, including hospitalization, the ceiling will be $1,000 US.
Ms. Chen, what's your view on prescription drugs?
The prescription drug use in the United States, in fact, is low compared to total health spending. Relatively speaking, in Europe as well as in Taiwan, the percent of money spent on drugs in terms of total health spending is a much higher percentage. Example, in the French system, it's roughly 25%. In Taiwan, 25% of total health spending is on drugs. So they have much greater access to drugs. That's number one. Number two, the reason why the drug price...
I apologize. My time has gone over. Senator Murphy has joined us, and Senator Murphy, do you have some questions you wanted to ask?
Yeah, thank you very much, Mr. Chairman. Thank you for this hearing, and to all of the witnesses. I'm sorry I had to step out for a few moments. I guess I just sort of had one broad question for the panel, because I think it's come up in some of the testimony, especially I think from Ms. Pipes and Dr. Martin. And I'm always fascinated by this intersection between convenience and quality. And to the extent to which metrics like wait times often don't automatically translate into differences in outcomes. Often they do. I mean, there's some services in which if you don't get it right away, it's going to have a pretty severe consequence on your health and on the amount of money you're going to spend later on. But, you know, there are parts of this country, for instance, that have enormous convenience, that you can't drive more than a couple miles outside your door and without finding an MRI machine or a dialysis center. And, you know, there's healthcare all around you. And yet that doesn't seem to be adding to quality. That seems to be adding to convenience. Similarly, I hear all of the stories from Canada that Ms. Pipes talked about in terms of wait times, and yet when we sort of look at all the underlying data, it tells us that, you know, in the end, on a lot of the diseases where you have wait times that might cause you to question the system, the outcomes in Canada are fundamentally better than they are in the United States, from heart disease to cancer. So that's not to say that we shouldn't sort of look at issues of convenience and issues of wait times and your proximity, either spatially or temporally, to services. But I wanted to kind of, I mean, specifically kind of asking Dr. Martin and Ms. Pipes to talk about this, but maybe asking others in the panel who have thoughts about this with your experiences, to talk about how in other countries where there may be less easy access to health services, not as much health care as we have in the United States, we have tons of it, as to whether that actually has a true relation all the time to the outcomes that we get. Dr. Martin, happy to have you start.
Thank you. It's a really thoughtful question. And I guess I might reframe it slightly by saying that what you refer to as convenience, I would refer to as patient experience. And so when we talk about quality in healthcare, the so-called triple aim, coined by Don Berwick of the IHI here, the notion of quality having three dimensions. One is population health outcomes, on which single-payer countries like Canada fare, in fact, quite well. Another aspect of the triple aim is cost per capita, and the third is patient experience. And of course, patient experience is important. And so, you know, I said that I wasn't here to be an apologist for every single thing about the Canadian healthcare system. We're working very hard on reducing wait times for elective surgeries because we believe that patient experience matters. But you're right that our outcomes are very good. And I think it's critically important for the committee to understand that single payer does not equal wait times. We heard our colleagues from Taiwan tell us quite clearly that they have a single payer system with virtually no wait times, with 99.6% coverage of the entire population. And so, of course, we should consider all aspects of the triple aim when we talk about quality, but we should not we should avoid oversimplifying the message and equating a single payer model with wait times. That simply is not the case.
Madam Justice Marie Deschamps, who retired from the Canadian Supreme Court in 2012, in that hearing in 2005 said, the idea of a single-payer healthcare system without waiting lists is an oxymoron. So I just want to make that point, that even, and the Canadian Supreme Court is not a conservative court by any stretch of the imagination. I think, you have
But do you dispute the characterization of the Taiwan system?
Well, the United States, I think, as Senator Burr said, we have 315 million people here. We have such a diverse, we do not have a homogenous society, which is much more typical in many other countries around the world. I did want to make a point about life expectancy, and the WHO, the World Health Organization, often says the United States ranks 37th out of 190 countries. Well, as Professor Stephen Wolfe, who was the lead author in the Institute of Medicine study, which, was really based on life expectancy and infant mortality rates, he said life expectancy and other noted health outcomes are determined by much more than health care. And here in America, when you look at our lifestyle choices, we have a huge obesity problem. We have homicides and car accident deaths at a much higher per capita rate than any country in the world. So when you look at the numbers for 5-year survival rates on cancer, based on the work done by Lancet Oncology, the United States ranks #1 in the world on 13 of the 16 most popular cancers. So you have to be careful when you're doing statistics that you're comparing apples to apples.
Well, great. Thank you very much. My time has expired, Mr. Chairman.
Senator Burr.
Thank you, Mr. Chairman. Let me say before I ask the second round of questions, there's been a lot of reference to Medicare and single-payer system. Let me just remind everybody, in Medicare, for a working lifetime, I pay into a system to finance part. There is a government share. When I become a senior and I go and get Part B coverage, which is the physician side, I pay a premium for that. When I go to get drug coverage, I pay a premium for that. You can't look at Medicare and say this is like the single-payer system in Taiwan, where the government picks up the entire tab. Now, health care is not free. We all know that. It comes out of general taxes. But there's a difference for seniors in America that they are personally invested into a system, and they even have choices. They can choose a Medicare Advantage, which is a private sector coverage. At least they could before Obamacare, and now that's getting knocked out. And they can choose as a senior to buy Medigap insurance, so they can buy their way out of skin in the game. The one thing that I heard is that everybody, except for possibly Taiwan, has some degree of copay. France does, Canada doesn't, but they do as it relates to drugs because they're on their own for drugs. And what I want to talk about is drugs because, Ms. Cheng, Dr. Yu, our friend from Taiwan, said in his testimony that patients in Taiwan can experience delays in coverage for new drugs and new technologies from 2 to 5 years from adoption of the United States in that. And Ms. Chen, you touched on prescription drug prices in your testimony. Almost all countries enjoy the benefits of America's medical research and development, but developed countries don't pay their fair share for the immense expense involved in the development of innovative life-saving therapies. These countries are free riders on the United States by enacting price controls on drugs and devices. How would sharing more of the financial burden that comes with research development of life-saving drugs and devices affect comparison between the United States and the countries we're discussing today? That's to you, Ms. Chen.
Thank you for this question. First of all, yes, United States does fund a whole lot of R&D in pharmaceutical and other device innovations. But in so doing, we are also helping to make the American healthcare system that much more expensive. In fact, so expensive that we're pricing people out of the healthcare altogether. So United States is so in terms of R&D in single-payer systems, I think it is the governments of these systems can set aside specific R&D funds to help with R&D for innovations.
Ms. Chen, in the U.S. system, when we shifted from exclusively doing bypass surgery for heart blockage,
right.
And we went to catheterization because innovation allowed us, or technology allowed us to do catheterization. Do you consider that to be a cost savings to the United States or the expense of a new innovation?
if it is done on the right patients at the right time, yes, it is a cost-saving innovation and application of that innovation. However, I think with United States healthcare, there's a very serious issue which has not been addressed, which is overuse of services. We have here in my testimony, there's
in that the risk of letting the American people choose health care and having a marketplace versus having government dictate what, where, when, and how much?
It's not a matter of letting people decide in the marketplace where to go or what to choose, what to have.
We overprescribe grossly pharmaceuticals in the United States. Why? Because the American patient has the right to go in and ask their doctor, and because of our liability exposure, the doctor feels compelled to write the script in the United States. And I would tell you that's a lot of the health care, a lot of the drug costs. Let me just move.
May I just say
yes,
this? In a Institute of Medicine book, in fact, I brought it, it says that this overuse of everything, services, devices, drugs, it causes waste in the American health system. According to this Institute of Medicine book, about 1/3 of U.S. healthcare is waste, and $750 billion a year. And of that, unnecessary services accounts for $210 billion of the $750 billion.
I wouldn't disagree with the conclusion of that. I have one last question, Mr. Chairman, and it's to Dr. Hogberg. In contrast to what I've just talked about with Ms. Chin, price controls overseas don't reward innovation. If the United States were to follow the price control model, what would happen to patients' access to innovative treatments here in America as well as overseas?
In the long run, you would see less access to new innovative drugs. It'd be that simple.
So if in fact we eliminated innovation, in many cases that innovation which takes somebody out of a hospital setting, puts them in an outpatient facility, they're treated, they no longer have the risk of infection because of inpatient, they no longer have the days in the hospital. That's not only been beneficial to the cost in healthcare, it's actually beneficial to the quality of the outcome.
Well, sure. Frank Lichtenberg's looked at this extensively, and he's estimated that for about every dollar we put into pharmaceuticals, you save well over $3 in hospital costs by avoiding hospitalizations. The price controls can have one of two impacts. If you have a price control that's lower than the market price, you'll see a shortage. If it's above the market price, you'll see a sorry, I'm losing my train of thought here. You'll see a surplus, and that's kind of what you're going to end up with, a system of price controls.
I thank you. I thank our witnesses. I would ask the chairman for unanimous consent to allow us to submit questions to all the witnesses for the purposes of the record.
Absolutely. And this has been, let me thank all of you for being here. And I want to apologize. I would like to stay for another round of questioning, but we have votes that are taking place right now. So I think this has been a very thoughtful and vigorous discussion, and I appreciate all of you very much for being here. Thank you. This hearing is adjourned.